All right. Good afternoon, evening, and morning, everyone. My name is Jazz, one of the CP Solvers members. I am excited to co-discuss with the one and only Jeffrey Shen. I'll give it to him in a second to introduce himself, and then we'll then go in order of the scribe and teaching team, and then the case presenter, Vinny, to introduce themselves. Jeffrey?
All right. Hey, for those of you who don't know me, I'm Jeffrey. I'm one of the Duke rheumatologists, one of the new Academy members. I've been really grateful and excited to learn with all of you these past few months, and definitely very excited today to be able to co-discuss with Jazz. Yeah.
Hi everyone, my name is Julia. I'm a medical graduated from Brazil and I'm excited for this case too.
Hello, everyone. Thank you for joining, and I'm very excited for Winnie's case and discussion by Jeffrey and Jazz, a J&J session. So looking forward to it.
Yeah, so hey everybody, I'm Vinny. I'm a final year medical student and I'm super excited for today's case and yeah, let's start it.
And then, Jeffrey, do you want to take the first LCAT or do you want me to take the first, do you want me to go first?
I'll let you go first, and then I'll go first the second aliquot. We'll trade off.
Sounds good.
Okay, so the first aliquot, we have a 38-year-old male who presented to an outside hospital 5 days ago for numbness and tingling in his hands and feet, with bilateral feet hurting so bad that he's unable to ambulate and has a rash. The patient was transferred to our hospital for further investigation and management. And other than that, the patient was diagnosed with Raynaud's phenomenon and disease 5 months ago due to bilateral painful slash frozen sensation in his hands associated with color change when exposed to cold temperatures. He also had persistent intermittent numbness in his left arm for 3 months. And 1.5 months ago, he started to feel a numbness and sharp pain in his right foot that progressed to the left foot within 2 days, and then it started to ascend up to like to ascend up to other extremities, to lower extremities. He also describes it as a frostbite. And a month ago, he reported having a sensation of pain in his right foot, followed by a painful red dot-like rash that appeared 1 day after. So first the pain and then the rash. The rash has been slowly spreading bilaterally to both limbs. And she also states that he saw his PCP for the symptoms, who scheduled him to see a neurologist and prescribed some gabapentin. And the PCP never tried steroids or any other medication other than the gabapentin. And also, about 1 month ago, he started to have occasional shortness of breath with exertion, roughly after walking around 30 steps. And yeah, that's basically that. So do you want me to summarize, or is that clear?
I think I think I got the gist of it. Plus, Julia's doing a great job of capturing everything. So I think that's good, Vinny. Is this where you want to stop for the first LQAT?
Yeah, I think that's a good place. And just to, I don't want to jump in the physical exam, but as I'm describing the rash, I think that you guys would benefit for seeing when you're interviewing this patient. Okay,
Sure.
so let me put that here. That's the rash.
Also, I just want to say that, like, Jeffrey, I'm so glad that you're the co-discussant. Just want to say that. Okay, perfect. And can you just see? Can I just see the feet one more time?
Yep.
Okay.
No, no.
Uh, And then the third picture. Okay. All right. All right, so lots of information by Vinny on the first aliquot, which also helps paint the picture of what the how complex this patient is going to be. Vinny could have easily started off by saying this is a patient that comes in with 5 days of numbness and tingling, but he paints a picture of someone that is actually not just suffering for 5 days, but months, which tells you the chronicity of this issue, and it tells you that there's a subacute, maybe even chronic imprints to what's been going on. And clearly, in the last 5 days, it led to a point where there was a tipping point where it got to the point where he needed to come in. And it seems like from Vinny's description, it was the pain. The pain got so severe that he was not able to ambulate anymore. So from the rich history that Vinny provided, there was a couple of things that kind of stood out. One was obviously the rash, right? So the rash, and I'm so glad that I'll be co-discussing with a rheumatologist. Jeffrey, if I say anything that's incorrect, please correct me when you discuss the case. The rash to me, at least without putting my finger on it, looks like a petechial rash. And just to recap, what that means is that the red blood cells have extravasated out of the blood vessel, so they have actually deposited into the skin. So I would say this would be a non-blanching rash, especially the one on the shin. And it didn't look like palpable purpura, but more like petechiae. So I don't know if I would, if I put my finger on, if I would be able to feel it, at least just on the picture. And I think the based off Vinny's description, and I could be wrong, but it looked like a more of a small fiber neuropathy. It seemed like it was mostly the feet. But also the thing that came to mind was neuropathy multiplex. It seems like his hand was involved, and it's like, or upper extremity. Then first individually one side of the leg, and then the second one happened afterwards. But it's tough to say. It could be polyradicular, polyneuropathy. But right now, that does come to my mind. I think the Raynaud's phenomenon is just interesting. It's just a non-specific way of, it could be a whole host of things. It's not always has to be associated with scleroderma, but I'll defer to Jeffrey to comment more on that. But I think for now, he's in a subacute context where I feel like he wouldn't probably have bacterial endocarditis, but I still think a non-emerentic or atypical organismal endocarditis should also be considered, whether it's a cholesterol emboli or endocarditis secondary to like a fibronic, like a lupus or like a Lehman-Sachs type of situation, or if he had any risk factors for APLS. But I think to summarize and to pass it over to Jeffrey for him to correct me if I'm saying right. I think the most thing that I'm concerned for this patient after this first aliquot, if I had to sum it up, would be vasculitis. And with this whole cold phenomenon, I would probably, that doesn't necessarily mean it's cryoglobulinemia, but I would definitely have that on my list, anywhere from ENCA to PAN. So I think I'm concerned for mononeuritis multiplex, small fiber neuropathy, and it's a subacute time frame, which makes me think rheumatological conditions are highest on my list.
Wow, yeah. Thanks so much for letting me discuss with you. I think you already kind of hit all the points that I agree with in terms of how to characterize this rash. From my limited knowledge as well, would also describe it as petechial. And the presentation does seem concerning for vasculitis. I will say if we, kind of take it at face value with the different nerves being involved one at a time and now kind of multiple being involved, does seem very concerning for mononeuritis multiplex. So I'm going to start with the neuropathy first, and from just a rheumatologic point of view, kind of discuss my thoughts. So when we think of mononeuritis multiplex, it's classically vasculitis, which is the cause of that. So what are the causes? Which vasculitis cause mononeuritis multiplex? So this is how I remember it. So the muscles and nerves are affected by small and medium vessels. So we're looking essentially for a small and or medium vessel vasculitis. So we're not thinking about GCA or Takayasu's. So on the small to medium side, the things that we are looking for are for things like ANCA vasculitis, which includes MPA, GPA, and eGPA. Out of those three, the most common in descending order is eGPA, then GPA, then MPA. The reason the eGPA has the most common is because the eosinophils like to infiltrate the nerves. So those are one set, which we can look at for ANCA and through other history. Another set to think of is IgA vasculitis, which can be very complicated because it commonly can occur after infection. So you can get very, very complicated cases where you have multiple things going on at the same time. As well as cryoglobulinemic vasculitis, which can also be secondary to either an infection, an autoimmune disease, or a malignancy, or multiple of those, and also very commonly causes painful vascular neuropathy. Those are the most common secondary causes of vasculitis to think about. But another really important subset to think about are non-rheumatologic causes of vasculitis. So Jazz already mentioned the possibility of endocarditis, which is a very close mimic of vasculitis. Multiple causes of culture negative infective endocarditis and causes of non-infective endocarditis can mimic vasculitis. Drug-induced causes of vasculitis, such as from hydralazine, should also be considered, and levamisole from cocaine. They can also appear as a petechial rash, and they can cause paresthesias through different mechanisms. And finally, there's something called non-systemic vasculitic neuropathy, and that affects mostly only the skin and the nerves, and that's also on the differential. So from right now, these are kinds of things I'm thinking of. Just from the neuropathy standpoint, if I add the shortness of breath, the hemoptysis to the picture, the Raynaud's, what I'm thinking already is a vasculitis that potentially is affecting the lungs, and that puts me towards the ANCA vasculitis category. And that's all I'm going to say for now.
Wow, that's amazing. What a discussion. So moving on, the patient presented to the ED, to the outside hospital, like 5 days ago due to worsening of the symptoms, as you guys could see. And the redness that were present were improving, but the shooting pain and weakness in the bilateral lower extremity has persisted. So aside from that, the hand symptoms had significantly improved during this visit. So review of symptoms, the patient endorsed some joint swelling, but denies joint pain. He also refers morning stiffness that takes several hours for the joints to loosen up, and fatigue. And she denied any kind of fever, photosensitivity, DVT, symptoms related to pericarditis or pericardial effusion, or history of psoriasis. And additionally, the patient, like when you're interviewing and asking to talk more about the shortness of breath, he says that is related to exertion, and when he walks a little bit, and but other than that, it's nothing that not very distressing, and deny any kind of chest pain, vision changes, GI or GU related symptoms. Okay, moving on, past medical history of, as I said, Raynaud's phenomenon, recent diagnosis of polyneuropathy, and vape use. Meds, he does not take any kind of meds. Social history, the patient lives in a house with his brother and sister-in-law in Cleveland, and is not sexually active for the past 6 years. He works remodeling bathrooms, and health-related behaviors. Patient denies any alcohol or recreational use, and vapes, but denied like smoking cigarettes since 2007. So just to summarize, we have this middle-aged man with the history of polyneuropathy and Raynaud's that is presenting to our hospital, was transferred to our hospital for the investigation. And after brushing the mononeuritis multiplex clinical picture, the gabapentin didn't work, haven't taken any steroids, and that's it. Do you think that's a good? I think that's a good place. It's a short aliquot, and if you guys have any additional thoughts, I can stop a little bit and then moving on to physical exam and some labs.
Okay, yeah, I can start. So, it's really helpful, that we have a good social history, as I had explained earlier. Like we're looking for things such as exposures or habits that can sometimes make this a little bit more complicated. Specifically, like drug-induced vasculitis from medications would be a very, very common cause of skin, and sometimes with neuropathy. But the patient's not taking any medications, it's not doing any drugs. It's not doing any alcohol. So a lot of causes of toxic neuropathy or toxic mimics of vasculopathy are gone. Um, other thing in the social history, I guess, if they're from Cleveland, just from an area perspective, infectious causes that can mimic vasculitis. So I'm not completely aware of all the different infections that can mimic or cause vasculitis, but I know Lyme disease definitely can cause neuropathy. I'm not sure if it can cause a vasculitic appearing rash. Also not we don't have it down here really in North Carolina, but I'm not sure if in Cleveland you can get that or not. Histoplasmosis comes to mind when I think about Cleveland, but this whole entire picture so far, nothing really speaks to me for histoplasmosis except for some of the pulmonary symptoms. So I think right now, like with this history, I'm still thinking that most likely it's in the rheumatologic category, some type of vasculitis. Jazz, I'll go off to you for any other thoughts.
I think it's unfair for me to go after you. It would be hard for me to add much, but I think I would just like summarize like the primary features. So this is a patient that like subacute, painful bilateral lower extremity, like polyneuropathy slash mononeuritis multiplex, joint swelling, but no joint pain. With this history of Raynaud's and morning stiffness, gives me a flavor of connective tissue overlap. Um, and then hemoptysis and exertional shortness of breath tells me there's pulmonary involvement. So and then not to mention the petechial rash. Just by that summarization alone, this is a systemic disease. It is not selective of where it's attacking or where it's primarily harboring its nest. It's going everywhere. So what goes everywhere? Nerves, blood vessels, and connective tissue. So I agreed that this has a flavor of like a rheumatological condition. The only thing I'll add is the occupational exposure, like silica, chemicals, mold. But the thing is, it doesn't explain any of the other symptoms, at least not right now. So um, I feel like I shouldn't go into the different types of vasculitis it could be, but I think right now with the limited information without labs, it was really good pearl that Jeffrey shared that like this makes small vasculitis more likely, but with the lung involvement, with the rash, neuropathy, and with the age distribution, could this be microscopic or polyangiitis or MPA? I still think cryoglobulinemic vasculitis or any other just connective tissue related vasculitis, but Jeffrey taught us something recently that says that, the diagnoses that we have in rheumatology, there's no concrete and there's no lab that says this lab is associated with this one particular rheumatological condition. It's not the most greatest way to delineate that. And I think that was such a fascinating pearl that, even if you diagnose somebody with one particular disease, for example, ANCA-vasculitis, that it could also be something else if in the right context. So I would just use this time to summarize, and I'm excited for the next Saddle Club.
All right, amazing. So moving on, physical exam, patient has a blood pressure of 150 to 90, 74 of heart rate, afebrile, normal saturation of 97 on room air, BMI of 21, And the pertinent findings in the physical exam is the rash, as you guys could saw, they characterize as a convalescence, non-blanching petechial macules on bilateral lower extremities. VLA shows small retiform patches on the abdomen, and the extremities, bilateral lower extremity ankle pudendal edema, it's just 1 plus 4. And lungs was normal. They were concerned in the outside hospital, but was normal. And narrow, the guy can move all 4 extremities now, no focal neurologic deficits. So he presented to the outside hospital like 5 days ago, really without moving his limbs, but he improving. He now can move. Okay, so some labs: WBC of 4.7, hemoglobin of 10, hematocrit of 29, platelets of 146, and chemistry, sodium normal, potassium normal. Yeah, let me see if there's anything pertinent here. Creatinine normal, and calcium also normal, 8.6. AST and ALT mildly elevated, of like in the range of 80s. ALP, GGT, bilirubin, albumin, INR, all normal. Iron panel, the iron was in the lower threshold, 40. TIBC was normal. Transferrin saturation was decreased at 14. 13 of 81. B12 and folate was both normal. And HIV and syphilis was negative. C ANCA and P ANCA was negative also. And in the outside hospital, they like a bunch of multidisciplinary and other specialty teams saw the patient and asked for some tests. So that's the reason I'll say them. So imaging, the CTA of the chest was normal. The ultrasound of the kidney shows no signs of hydronephrosis. It was normal also. And in the CTA of the abdomen and pelvis, there's marked splenomegaly with multiple borderline sized abdominal nodes. That's all. And the MRI of the brain was normal also. That's a good place to stop.
Just want to confirm one thing. Do you have a UA or was it normal?
Yeah, the UA shows more than 25 URBCs, but other than that, normal.
And so no proteinuria, just hematuria.
No proteinuria, no.
Okay, thanks, Vinny. Okay, another very rich aliquot. So yeah, I think the most striking thing was the CT abdomen pelvis. But before I get there, so vitals, low hypertensive, otherwise, reassuring, not requiring any oxygen requirements, and more notable, no crackles or abnormal lung sounds noted on the exam. So that tells us that, and then that was further confirmed by a CTA chest that did not, I'm assuming, show any ground glass opacities or any other infiltrates that may have correlated with the dyspnea on exertion and this questionable hemoptysis. So that was reassuring, at least for now. There are certain diseases, like for example, ankylosing can cause a fleeting infiltrate pattern where it causes hemoptysis with this diffuse alveolar hemorrhage, and then a few days later you get a CT chest and it's completely gone. So it doesn't completely eliminate it, but I feel like that does bring into query of the lung involvement of this disease. In terms of the neuro stuff, this is progressive sensor motor peripheral neuropathy, and it seems like, based off Vinny's description, it is improving a little bit. The pinning edema of the ankles, I'm not going to invest too much energy into that. I think just that tells you there's systemic inflammation going on. If we were to check a CRP on this patient, I would imagine it would be pretty high. And then or ESR, because just a side note, with lupus, ESR would be elevated, but CRP typically is not very robustly elevated. And then I think the P-ANCA, C-ANCA being negative doesn't really tell us much. I'll let Jeffrey go into the specific percentages, but in normal P-ANCA, C-ANCA does not necessarily rule it out. And the best way to do that is to get a tissue biopsy. So I think for me, the CT abdomen and pelvis was by far the most striking thing with this very large splenomegaly and these abdominal nodules. Maybe it wasn't listed in the CT of where these nodules located, but I'm just going to take a guess and say that it was kind of diffuse and not in a particular pattern or geographical location. I am a little now concerned with a malignancy associated or autoimmune overlap, and I'm now like slowly shifting my needle. Like, could this be a lymphoproliferative disorder with vasculitic manifestations? Cryoglobulinemia could still be that, like often usually linked with like a low-grade B-cell lymphoma. It's reassuring that some of these like the HIV and the syphilis is negative because that can explain the CT abdomen finding, especially with splenomegaly and the rash. I think I would check a complement level here, especially with the UA showing hematuria. I don't think we've completely ruled that out. And I would also get an SPEP and UPEP in this patient with a kappa to lambda free light chain ratio. And then, yeah, I think that I'll pause there because I really want to hear Jeffrey's discussion here. Like, I think I would still say this is rheumatologic, but I'm just with the nodules, there are certain autoimmune conditions, like IgG4 disease and other ones that can lead to a physical, like a mass type of imprint. Sarcoidosis is another one. But typically the nodules makes me it makes me a little bit more concerned. Like, could this be a fungal infection or a lymphoproliferative disorder with a vasculitic manifestation? So that would be my summary of this aliquot. I would love to hear what Jeffrey thinks.
Wow, this is becoming a very fascinating, crazy case. Well, I think I have to agree with Jess right now. The biggest problem here with this picture is the splenomegaly. And the reason I say that is most vasculitides that we have in rheumatology, so that's whether it's large like giant cell Takayasu's, medium like polyarteritis nodosa, and small like ANCA vasculitis IgA, they don't cause diffuse lymphadenopathy or splenomegaly. So if the spleen is truly enlarged, and it's not from a different cause, like for example, one way potentially you can get splenomegaly from vasculitis and not from it being an activation of the reticuloendothelial system is if you had an infarct. Rarely having an infarct in the spleen and then the spleen becomes bigger and to compensate for that. But if we're truly seeing like splenomegaly and there's no masses, really makes me think that this is not a primary or not just a vasculitis. And again, then the one, just as Jess said, like the one caveat is cryoglobulinemia can be very tricky. Uh, Rheumatoid arthritis very rarely can present with splenomegaly in a disease called Felty syndrome. But you would expect neutropenia, so it would be interesting to see what the diff is. And usually it's like very long-standing very long-standing rheumatoid arthritis that's seropositive that predisposes to that. And it overlaps really with this very rare type of leukemia caused by STAT3 mutations called large granular leukemia or large granular lymphocytic leukemia, LGL leukemia. Um, so it's interesting to see that in the context of vasculitis. I'm not really sure at all what to make of these abdominal nodules or nodes. I wonder where they are, but I at this point right now, I can't really think of any autoimmune disease that I've seen that has that characteristic that I've seen on the imaging. Jazz mentioned, for example, if we were to think in terms of rheumatologic diseases that could cause pseudotumors that maybe are being read as nodules. Um, IgG4 related diseases and sarcoidosis, those are two of the biggest ones, and very rarely ANCA vasculitis to cause pseudotumors. IgG4 disease, in a very recent review, we're still learning a lot about this very complex disease, but there's essentially like possibly two subtypes, one that's vasculitic and one that's not. In the vasculitic subtype of IgG4, these patients who often have an overlap with hypocomplementemic urticarial vasculitis, they can present with vasculitis. They can also present with these pseudotumoral lesions. Very often, though, the kidney is affected. I believe in most patients you have involvement in the lung and the kidneys, interestingly, in those individuals. So I think it's on the differential, but I wouldn't probably put it very high. I think it's definitely reasonable to check IgG4 subclasses just to see what they are. But I wouldn't hang my hat on the diagnosis unless we had a biopsy for that in order to diagnose it. And then for sarcoidosis, I mean, sarcoidosis can cause a lot of very weird things. But sarcoidosis is very rare to cause vasculitis. And also very rare for it to cause neuropathy. That's not small fiber neuropathy. A mononeuritis multiplex is a known presentation in case reports of sarcoid large fiber neuropathy, but it is extremely rare. And what you would need to do to prove that is get a nerve conduction study, then get a sural nerve biopsy and show that there's non-casein and granulomas there, and there's no other mimics such as Lyme, VZV, lymphoma, or leprosy. So there are a couple of routes that I think I would take here just to understand the picture. Um, One of the first routes is, additional serological tests, specifically looking for things like lupus RA. I would also get immunoglobulins here just so that I understand the picture. If the immunoglobulins are low, sometimes you can have common variable immunodeficiency, and that can present as a vasculitis as not like a paraneoplastic phenomenon, but almost you get this autoimmune phenomenon from immunodeficiencies. So I would look for those as well. You can get IgG4 subclasses. I would probably be repeating the urine testing and the complements, and then I would really look for cryoglobulinemia. From the infectious studies, I think the big ones that we don't have here that could make sense to get are things like hepatitis B and C, since they are both associated with vasculitides. And then finally, consideration for places of biopsy, either a skin biopsy or a nerve biopsy, depending on where it is, would probably be the first place that I would go to. But yeah, I'm very curious to hear what happens next year.
Yeah, that's outstanding. You guys like covered all possibilities and everything. So they were concerned for in the outside hospital, I mean, they were concerned for the possibility of malignancy. They asked for some and also some myositis due to the fact that the patient was not walking. And the polymyositis, sorry, I don't have the CK, but the polymyositis panel was negative. And they also performed an RNP antibody that was negative. The immunoelectrophoresis and protein electrophoresis reveals a spike of I like there's no definitive M protein, but there is a IgM that is 520 being the upper threshold of 230, but no IgG or IgA in immunoglobulins. Going to the complements, there is decreased C4, but normal C3. So C4 is less than 2. ANA was negative. Lupus panel was negative. Normal for lupus anticoagulant. Like there's no indication for lupus anticoagulant. And I don't remember if I said that, but IgG4 levels was normal also. And in the next aliquot, I'll reveal the diagnosis. That's a short aliquot also. Let me know if you guys need any other test that you want.
Okay, I guess I'll start this time. It looks like well, yeah, thank you so much for this really fascinating case. And I think what we had previously discussed and what Jas kind of brought attention to is a possibility of something like a lymphoproliferative disorder, which with these new updates in the labs is we're getting a little bit more signal there. So first we have some decreased C4, normal C3. And this is a typical finding that you would expect if the patient were to have something like cryoglobulinemia, which can explain a lot of these findings. And then along with that, we do have a high IgM. Not, I guess we're not sure right now yet if it's monoclonal or not. Typically, if it was a monoclonal IgM, you would be thinking about something called lymphoplasmacytic lymphoma or Waldenstrom's macroglobulinemia. You can also have rarely IgM myeloma, I think. And those disorders also are very commonly associated with type 1 cryoglobulinemia. And so it would make sense with a lot of the features in this disease, including neuropathy being a very prominent feature for those plasma cell dyscrasias. Um, the vasculitis part is interesting. I'm not as familiar with that being a very prominent feature of those neuropathies, although I certainly think it's possible if it's in the setting of cryoglobulinemia. And then the arthritis. Arthritis is actually quite common, and there's many reasons for that. If in patients with multiple myeloma, for example, you can have bone lesions that cause bone pain. But also, both of these disorders are associated with both a non-inflammatory arthralgia and a inflammatory, sometimes seronegative, erosive even, rheumatoid arthritis-like picture. So, interestingly, that's another a part of this picture that could be explained by that. And then finally, we don't really have a great explanation yet for the shortness of breath exertion hemoptysis. And I wonder, it may not be high enough. The IgM itself may or may not be high enough to cause this, but I wonder what the cryocrit is. But sometimes you can get increased serum hyperviscosity, and that by itself can, I believe, cause slowing of the blood flow in the pulmonary vasculature leading to hemoptysis. So I wonder if we get a serum hyperviscosity. See, that could be the cause of that. But right now, I think my leading diagnosis is something like Waldenstrom's microglobulinemia. I'll give the mic to Jazz and see what his thoughts are.
Yeah, there's no way I'm disagreeing with you. I'll tell you that right now. Yeah, but I think the first thing when I saw the C4 being low and C3 normal, I thought to myself that, like, I remember learning that being very characteristic of cryoglobulinemic vasculitis. Um, type 2 or type 3, so like an immune complex mediated. But I think I guess I don't really have much to add, to be honest with you, but I have more questions, and I feel like maybe we can like answer those like the question. Maybe you can help answer my questions. Jeffrey, what do you think of the nodules? Can cryoglobulinemia lead to like a nodular finding on the CT abdomen, or do you think that could have just been an incidental finding? Could this be like like what I said earlier? Could it be an lymphoproliferative process that led to the cryoglobulinemia? I would love to know your intake on that.
I honestly don't have much intake. I mean, I think in the context of this looking like a lymphoma, I wonder if it's either like a lymphomatous. I'm not really sure what these nodules refer to. I know, for example, you can get retroperitoneal fibrosis rarely with, no, it's typically not with these lymphomas, but like for example, Castleman's disorder, which is sometimes associated with plasma cell dyscrasias, can have that kind of picture where there's typically it's a mediastinal mass, but if we were to think about it in the abdomen, it would be like an abdominal mass or node or nodules. So I'm thinking of maybe it's more like that kind of picture right now, but I'm not sure how to put that together with the cryoglobulinemia itself. I don't think cryoglobulinemia would be able to explain the nodes.
Okay, that's what I figured too. And if you were to venture a guess, I'm assuming the RF that's being withheld for us is going to be high, but do you think this would be type 2 or type 3, or would you need more information?
Well, yeah, honestly, what my initial thought was that it would be type 1 because that's the one that is associated with like multiple myeloma and Waldenstrom's.
Mm.
But I think I could get, I could easily have gotten this mixed up, and maybe the IgM being high, it's not monoclonal, right? And this is maybe, for example, hepatitis C induced, in which it could be type 2 or type 3. We maybe have a little bit of elevated liver enzymes. So certainly, I think all of these types can cause it, and then the decreased complements are indicative of immune complex formation. I
Mhm.
believe that actually you can get that with all the types, but I might be wrong about that as well. I don't know that it's how specific it is for being just type 2 and type 3. So, maybe I was misled a little bit by thinking that this was the IgM maybe is leading towards a monoclonal component. But I can see all of them causing this type of picture. We just need to know what the cause of the cryoglobulinemia is, I think.
Awesome. I can't wait to hear the answer.
Yeah, that what a pristine discussion. I'm amazed. Yeah. So the rheumatoid factor is elevated, 500. And yeah, for educational purposes, I heard also the Hep C test that was very positive with a viral load of more than 5 million. And and if you put in the logarithmic scale, that would be on 6.3. I don't know how you guys are used to interpret that. The genotype was genotype 3, and the cryoglobulin was positive for IgG in the 200s, and IgA and IgM. IgM in the 200s also. So just to put all the things together, it's interesting because both the hemoptysis, there's no clear explanation for what I could saw. And the patient had a nodule of 5 millimeters in the lungs. I hold that also, but there's no like diffuse alveolar hemorrhage, and there's no other clear explanation for the hemoptysis. And I think that that's more noise, but even if that's noise, I don't know how to explain that. And the nodules in the abdomen, the nodes in the abdomen also, I don't know how to interpret that, but I don't think that's related with those things. But all the other things, it like fits, like the mildly elevated, as you guys said, liver function tests, the splenomegaly, the I don't know what the component of portal hypertension would be present in this patient. And other thing regards to history taken that was interesting, like the patient was a very religious guy, and then he said that we asked for IV drug use and other stuff, and he in the first day he denied it, but when with the results of the Hep C came back, we asked it again. Hey, you're sure? And can you remember something? And he remembered that more than 20 years ago he once had used it, and but he honestly couldn't remember that from a long time. And there's like other than that, the IgGM that was slightly elevated. It's also like the component of the cryo. And the kappa lambda ratio was, I forgot to mention that, sorry, was of 2.2. That is elevated also. That fits the explanation of the cryo and the production of the cryoglobulins. So yeah, I will stop here and let what you guys think. They consider it as a mixed type 2, type 3, mixed cryo.
What an amazing case, and I'm just grateful that I had to discuss it with a co-rheumatologist. Jeffrey, what are your thoughts?
Wow, amazing. Yeah, amazing case. And I think this is a great learning experience for me, definitely. I think looking back, just like after you're discussing, I was looking at the IgM being high, and I thought, I guess from that if it was a monoclonal antibody, it would make a lot of sense with Waldenstrom's. But now in retrospect, the cryoglobulin in IgM is high, right? So that really does indicate that there's a polygonal hyper, well, not gamma globulinemia, but whatever the M stands for, mu globulinemia. Um, So I think that's just an interesting learning factor for me, and what an incredible case. And yeah, thank you so much, Vinny, for presenting this case. I really enjoyed it.
Yeah, thank you
Awesome.
so much. And I was like amazed because when we were doing like discussing the case, doing rounds, there's like the small pieces of the history that besides the history was very well taken and presented. Uh, there was some little inconsistencies, and then when you have the slightly elevated AST, ALT, and the kappa-lambda duration without having the clear clinical picture. We got stuck, and we start to hypothesize more rare diagnosis, involve a lot of medical teams, and then in the end, like it fits all the things in the end. So that's nice to see that everything what makes sense, you know. It's a little bit like frustrating when you investigate, and then a lot of things does not make sense. But in the other hand, as this case, as an example, like all the things could make sense, you know. So thank you for letting me present.
All right, awesome. Let's get Simi to do her wonderful teaching points.
Thank you, Vinny, for bringing such an interesting case, and Julia for scribing. And I really loved the discussion. And after such wonderful teaching, I have nothing to add to this. So I will just give a very brief summary. And I was just amazed by how we were just talking about vasculitis and cryoglobulinemia in the first aliquots discussion. And then the final diagnosis was mixed cryoglobulinemic vasculitis secondary to hepatitis. So we began our case with rash, numbness, and pain. So we were thinking that whether it is medium or small vessel vasculitis, because these are the types that usually affect vessel and nerves. And then given the patient's rash, splenomegaly, we also talked about possibility of rheumatoid arthritis, and we were thinking more about a systemic disease, whether it is malignancy, whether it is autoimmune disease, or is it vasculitis with all the symptoms this patient was having. And the final diagnosis of mixed cryoglobulinemic vasculitis was made. And thank you so much, everyone, for joining. I got to learn a lot.
Amazing. Such a great job of distinct teaching points. Thanks everyone for joining. Jeffrey, it was a pleasure. And Julia, great job on the scribing. And Vinny, always such a masterful presentation skills. Have a great Wednesday, everyone.
Thank you so much.